Nice to see some familiar faces in the crowd. Welcome everyone. So I've sort of been asked to talk about, I suppose, neurology and the medical management, I suppose, of Huntington's disease. But an overview, I'm going to talk a little bit about healthcare providers who are involved. I'll be able to skip over that because of our previous speakers have covered that. A little bit about multidisciplinary teams, just for those who aren't familiar with, because I realise it's a mixed audience. And we in the services know about, what you even had a shortened for MDTs and stuff. So, but just so people understand what that means, a bit about the symptoms of Huntington's disease, treatment options, and finishing with a little bit about clinical research. And I'll talk about our clinic as well a little bit. So these are some of the healthcare providers, and it's not complete. I haven't got exercise physiologists up there, I realise, and I had to add some other people. But from a medical point of view, you'll have your general practitioner, the geneticist will be involved, potentially in pre-symptomatic diagnosis, psychiatrists, very important, and neurologists, palliative care physicians. You might have orthopaedic surgeons if you fall over and break things. So there's obviously other medical people, but they're the kind of core medical people in the staff. Then we have a lot of other people involved, genetic counsellors, psychologists and neuropsychologists, and just so you've got a bit of an idea of the difference. So in Queensland it's a bit puzzling because a lot of people are both, in fact, compared to other states. But a psychologist is normally someone who treats the patient, who deals counselling and gives you strategies to deal with Huntington's disease, the stress of it, anxiety, those sorts of things. A neuropsychologist primarily tests cognition, cognitive function in Huntington's disease. Now, as I said, in Queensland, we're lucky because most of the neuropsychologists are actually dual trained and they're also psychologists, and we're lucky with the team we have that they can also provide some advice, because some neuropsychologists just do the assessment and that's it, and you just get a report at the end of it. But it is important to kind of pick out which areas of the cognitive function are and aren't working. Nurse and nurse practitioners, social workers. I gather a social worker spoke earlier, I think. Is that right? Yeah. Speech pathologists, important. We've heard, some great... We haven't got the luxury of having occupational therapists in our clinic. I've worked with them in multidisciplinary teams, and it's really some great hints that we heard there, specifically for Huntington's disease. And physiotherapists. So that's a non-inclusive, but you might come across all of these people on your journey, and I haven't even touched anywhere within the whole NDIS spectrum, which I suspect the social workers talked about, care workers, care providers. I can't even remember all the NDIS lingo. So a multidisciplinary team, what's the purpose? It's kind of something that's relatively new in healthcare. Certainly in some areas of healthcare they've been doing it for a long time, but it means there's a team of people from lots of different disciplines, lots of different people from that group that we saw before. And I don't always get to work in a multidisciplinary team, and I'm working as a sole trader a lot of my time, and I really enjoy, and there's a lot of benefits, I think, from a multidisciplinary team for those of us, particularly a lot of the medical people who don't always work there, it improves communication rather than someone sending emails and letters, not getting it in time. So it's really helpful for communication. Everyone's on the same page. I think one thing that's really good in our MDT is it provides training. So you learn off what someone else is telling you during the meeting. You learn something. Like today we've heard from the occupational therapist some things. So that's a really important part. And the multidisciplinary team meeting at the end of our Huntington's clinic, which is about this time usually on a Friday. No, it's later than this, on a Friday afternoon. We enjoy it, and I enjoy doing it even though it's late, because we always learn from each other. That's important. It does avoid the duplication of services. We can do all things at once to some degree, so it saves people seeing different people at different times. I think importantly it allows us to set priorities. If a person with Huntington's disease, I hate the word client, but they are clients, they've got to call them clients, but a person with Huntington's disease are seeing lots of different health professionals, and we've got to work out what we're going to do when they've all got plans. Setting priorities of how to do things in order can really only be done with some sort of negotiation in MDT, so it's really helpful for that. And therefore, sometimes that can be efficient for the patient and client. The problem with it is it can be difficult to organise, to get everyone in the same place at the same time. I think that COVID has meant that we've become much more adept at doing online meetings, and it's become more the norm rather than the exception. So it's actually had some benefit for MDTs, and many MDTs now are all done online. They are time consuming for the members of the team to sort of schedule that time, and that can be difficult depending on what other services they have. And I think one of the issues is that it's great having everyone together, but often when you sort of say, well, who's taking minutes or who's actually going to record this, that's a problem as well. So that's one of the issues that we have to think about. But you'll come across this in your journeys and in the journeys of your family members with Huntington's disease. A little bit about our clinic, and I can see some familiar faces from the old days of the clinics in the audience. But the clinic started in 1994 with Joan Lawrence, Professor Joan Lawrence, psychiatrist, and Professor Cecily Lander, one of my mentors, neurologist, a neuropsychologist, and Ira Simpson. So it was really came out of one of the early meetings after the gene was found in 1993, and this was a research clinic. I'm not absolutely sure, but I think it was the first clinic in the country. And we were collecting research information. It was a great dedication of Joan and Cecily to set this up. And we were sending across data to the Huntington study group, which is one of the big amalgamations that actually found the gene initially. And with the hope that with this research we would soon find some very effective treatments and cures. I actually first was in the clinic around that time when I was doing my early training. So not when the clinic very started, but certainly in 1995, I was in the clinic as a trainee. Then went away and did my training and came back as Joan and Cecily left with Dr. Rodney Marsh, who many of you know is a neuropsychiatrist, and we took over the clinic in 2001 and 2002. And we kind of changed the clinic for a variety of reasons. We stopped collecting the data for the Huntington study group, which was a concern because we were thought about the research was important, but it was a research clinic rather than being a clinical clinic, and we kind of changed the emphasis to a clinical clinic. We had the Huntington's Queensland welfare workers have been involved from very early, and I can see members in the audience who've been around for a while who've worked in that role and really supported the clinic over many years in a lot of different roles, especially in between when Ira Simpson was there and when we had a nurse coordinator where they were helping coordinate the clinic, which was fantastic. We had a speech pathologist starting in 2005, funded by Huntington's Association initially, and through some lobbying between some members of the audience and some members of the Friedreich's ataxia service, we had a funded nurse coordinator in the position since 2014. And we've had different people coming, different speech pathologists and neuropsychologists, but Rob Adam, who many of you will know, Dr. Rob Adam, my colleague who came in 2015, has really given me a lot of assistance as having another neurologist on board. The predictive testing clinic is separate. So that's the history of the clinic. So what is the clinic? We run a monthly clinic at the hospital. So there's a nurse coordinator, there's Rob and I, there's a trainee and a fellow. So there's often 4 neurology people involved. The neuropsychologists and their trainees are there. Psychiatry, Rodney Marsh comes, and often the trainees there, sometimes on their own, and we have an excellent speech pathologist. So this is the clinic. We don't have OTs, we don't have physios at the clinic. We see new cases, usually 2 or 3 new cases, and we review cases about once a year. And we have about 10 or 15 people in each clinic. But the numbers are growing, and we run 1 clinic a month. So the first Friday of the month, we don't have that on New Year's Day. So that's 11 clinics, and often another one has to be cancelled for one reason or another with public holidays. So there's a big demand on it, so there's a limited capacity. We have started doing some more telehealth, which has been helpful. And one of the great advantages of telehealth is that we actually can see patients in their own environment, which is helpful. And it also means that patients and the carers who otherwise, particularly from regional areas, would have to take the day off work to come in can stay at home and see the patient there, which can be really helpful. So although we lose, obviously, we can't assess people as well with telehealth, there's a lot of advantages in telehealth. And we're still very much supported by the Huntington's disease welfare workers from Huntingtons, Queensland. So a little bit about the clinical features, you know this, but just to run through some from a sort of a clinical medical point of view. We know the age of onset is typically from the mid-30s to the mid-40s, but we've seen, sadly, some very young people with severe disease, and occasionally we've seen people, I don't know what the oldest person I've had diagnosed, I've certainly had people in their mid-70s who've had their first diagnosis of Huntington's disease then. 81? So they're often working, childbearing age, driving, so it's a critical kind of time when this diagnosis is made, especially if it's out of the blue in a family where it's not known. So less than 20% have their first symptoms after the age of 50. So it's uncommon. Most people are under 50, but those who are older have a slower progression, and we know that those who have onset before the age of 20, the juvenile cases have a faster progression. So we know that the younger you are when you get it, more likely it's going to progress a bit faster. And the average age of survival, and this is an old slide, so I'm not sure this is actually still quite correct with increasing and improving treatments, but this is sort of the average age of death. There's obviously a fair range, but we're seeing that this is a disease of early adult life largely. So the early motor features. People know that Huntington's disease is sometimes called Huntington's chorea. What is chorea? Well, chorea is this involuntary, unpredictable, rapid, jerky movements in different body parts. That's what chorea is. Patients also have this motor impersistence where they can't maintain steady muscle contraction. So they mightn't have involuntary movements, but you'll have patients before they actually have involuntary movements drop things because they just can't hold things, or they fall over and they suddenly drop. We also see it in looking at their eye movements. They have poor motor planning and sequencing. Simple tasks are good, but if you ask them to do 3 things in a row, that's the problem, and we do test that as well. They have reduced limb speed and coordination, and although this doesn't cause a lot of symptoms, when we're testing patients with Huntington's disease, we look at their eye movements because that can be one of the very early features. It's important in the diagnosis. So patients are jerky, clumsy and slow are pretty common symptoms they'll talk about. In the later stages of Huntington's, we still see the involuntary movements, but some people get dystonia, which is more of a sustained abnormal posture, can be sometimes painful. So rather than being kind of wriggly, they're kind of stiff in funny postures. They can sometimes develop features of Parkinson's, so they tend to be stiff and slow with very slow movements rather than extra movements, particularly the younger patients. They sometimes get repetitive movements. I said that chorea tends to be an unpredictable movement, but some people tend to do the same sort of movement over and over again. We know that they get postural instability and falls, and that does tend to be a late feature. I'm always amazed at some patients with severe chorea all over the place and they never fall. And you sort of think, how do you not fall, these patients? So it's surprising that that happens late, but I'm always surprised at how infrequently, generally, patients with Huntington's disease in the middle stages fall. They can become immobile, problems with continence, and we talk about this akinetic or lack of movement, rigid subtype in the young patients. So the very young patients tend to have less wriggles and to be more stiff. I'll go through this quickly, but there are some speech changes. So there's problems with articulations, it's imprecise. These are the sort of words that Shana uses in our clinic. They have trouble coordinating their breathing in time with their speaking. And so you end up with this breathing, this sudden forceful kind of talking where they have this funny breathing pattern with this explosive sort of talking, which can occur, and also happens with swallowing as well sometimes. So there's a lot of variability in the voice, and they kind of have a different rate. So the prosody is the speed and the fluency of talking, and they sometimes will talk very fast or very slow. So there's a range of that. And in addition to actually producing the sounds, there's also language deficit, so they can't think of the words and they have problems with actually language as opposed to voice production. We know that swallowing is a big problem as well, and that's because their neck posture can be poor. They have trouble actually delivering the food to the mouth. So the problem for some people isn't so much the chewing or the swallowing, but it's actually getting it from the bowl in the spoon to the mouth. But involuntary tongue movements can be a problem. Sometimes chewing is very inefficient, and that's a very common problem we see. Food can spill out because they don't use their tongue. The tongue doesn't work properly to throw it to the back of the throat, and they have inefficient swallow timing and coordination. I think we just take swallowing for granted a lot, that we kind of put something in our mouth and we chew it and we swallow it, but it's a complicated neurological process, and it's very commonly affected in Huntington's, which is why it's so valuable to have a speech pathologist, an experienced speech pathologist in our clinic. Nutrition's a problem. I don't know whether I had dietitian on my list before. I didn't. I should have. It was on your list. But they should be. Weight loss is common. They have difficult access to nutritious diet. I think our OTs have already covered a lot of this thing. But involuntary movements expend energy. They don't need to go to the gym, but you're going to the gym all the time, these patients. And so they do need higher caloric intake. They have impaired swallow, which limits the various options of what they can eat. And some patients become very apathetic and have trouble motivating themselves to eat. I'm sure some people in the room will be aware of that. So I think of Huntington's in sort of the symptoms in three groups. We've got the movement symptoms that we've talked about already here, with the speech and the swallow and the movements. Then we have the behavioural symptoms, and there's a whole range of these. We've heard about sleep disturbance and how important that is. I like the definition of sleep being a non-negotiable biological requirement. I'll have to think about that myself. These are rarely common early features. Almost very commonly, before you get many other symptoms of Huntington's disease, patients get irritable, short-tempered at outbursts. It causes a lot of stress in relationships, and we see it very commonly. And as everyone's coming to deal with the diagnosis of Huntington's disease, this can be problematic. It's very common to see patients who are apathetic. They're not motivated. You can't get them to do anything. One partner might be out at work, the other one's stopped working because of the Huntington's disease. They come home, why haven't you done the washing? You can do They're just sitting there doing nothing. They just can't get themselves. On the other hand, some people are too impulsive. They become disinhibited. So there's a really big range of symptoms we can see. Anxiety is very common. Depression is very common. Some patients have this obsessive compulsive symptom. That's not terribly common, but I've certainly seen that. And in occasional patients, we see psychosis, where they get paranoia or hallucinations. That's not very common, but it's not very rare either, so we see that. And then we have the range of cognitive or thinking or mental processing problems. And there's a range of these. We tend to think about that largely being a problem with executive dysfunction. What does that mean? Well, it's like the central processing unit that distributes the thing. If your computer's running slow, you need a new hard drive. It's because the thing that's driving and setting things in order isn't working. So they're the sort of problems: planning and sequencing, working memory, flexibility, thinking of one thing and being able to do another thing. Some would say males can't do that at all anyway. Shifting set, concentration. They can't concentrate. And certainly patients in the early stages of Huntington's who may be working in a high-powered job, this really can become a big problem. They can do the stuff, they just can't concentrate. They can't do two things at once. They can't change from one thing to another. Memory impairment and language problems. Word finding, very common early. The phrase length and the complexity decreases over time, and they have increasing difficulty understanding complex information. So there's sort of a snapshot of the sort of symptoms that we see with Huntington's disease, and I'm sure there'll be lots of nodding in the crowd from people who have Huntington's or people who are caring for people with Huntington's disease. So what are the things that we need to think about, me as a neurologist, as a doctor treating them? Firstly, we have to involve, listen to and support the family and carer. Now, I think it was very important what our OT colleagues said before, that you end up with these meetings where everyone's there except for the client or the patient. and it is important to involve the patient, but it's also important not to forget the carers, not to the exclusion of the patient, but to listen and support the family and the carer. You know, I think we all understand in the audience here that the carer burden of Huntington's disease at so many levels is just such a big burden. It's really important that the treating people listen and support the carer. Another plug for Huntington's Queensland. Utilise formal driving assessment. I'm not going to have a big chat, and I notice the OT skipped past the driving question. Everyone tries to avoid the driving question. Driving in Huntington's clinic is one of the worst parts of my job. I hate it, and everyone else hates it, and they leave it to the neurologist. But it's a very difficult assessment, and ultimately, because patients, everyone thinks they're good drivers, patients with poor judgment tend to be even worse judges of their own driving, and it can be a real problem. Taking away someone's driving when you're taking away their job and taking away everything else that they can do is very difficult for anyone in all parts of neurology that we have to deal with, but in Huntington's it's often very difficult. And we have to sort of work through that. That's difficult, and sometimes having an independent umpire making the decision, seeing someone drive and saying, look, I can't tell whether you can drive or not, let's test you driving. That's still stressful, but we often use that. Problem is it's quite expensive, and it's nice when if we can find ways for NDIS to fund that. Plan early, EPOA, I'm sure the social worker and others have talked about this, but we do this in our clinic as well now. Think about all of the bits and pieces, family planning, financial planning. There's lots of planning that needs to be done early, especially before the cognitive symptoms of Huntington's make it difficult or even unviable to make those decisions. And I think we just, we have to try to maintain an optimistic but realistic approach to new treatment trials and research as a sort of a general thing. What do we do in the clinic? I think that's important. We've got to be optimistic but realistic. So a little bit about the management. At this stage, we can't treat the disease, we're treating the symptoms. Drug side effects are relatively common, and we have to kind of balance up the side effects, particularly things like sleepiness, because sleep disturbance is already a problem, unsteadiness. Address alcohol and recreational drug use. Occasionally people often patients find alcohol kind of very helpful. It's really not hardly ever very good for the Huntington's brain, and so that can be an issue. Rehabilitation is limited by cognitive impairment, so sending people for a rehabilitation program doesn't always work. We explore behavioural options, and we've had some great advice from the occupational therapists, speech therapy. PEG feeding I'm not going to talk about in detail, but that's a big discussion about when someone can no longer swallow safely, should we be feeding them? And as a general principle, if someone has deteriorated in a degenerative disease to the point where they can't swallow to maintain their nutrition, we have to think, well, what are we actually trying to achieve by putting a tube in? That's a whole question. It may have been discussed at other meetings, but it's an important thing that we sort of try to address so that wishes are known, because sometimes we find patients have feeding tubes put in when they're outside the usual care, and it ends up not being what the patient really wanted. And we've heard from palliative care as well. A couple of things on the drug therapy. So for chorea, we have got some treatment that can be quite helpful for chorea. Chorea is sort of due to an imbalance of too much dopamine, so we can block dopamine with a variety of drugs. Tetrabenazine is a drug that we use and can be quite helpful. And we also use some of these antipsychotics, risperidone, haloperidol. So these are really the main drugs we use in the Huntington's clinic. There's not a great big long list of them, and they can be helpful. And then there's a whole range of the usual treatments that we use in psychiatry for anxiety, depression, irritability, obsessive compulsive, apathy. Sometimes we use these, but they have a range of side effects that can be limiting. But we usually get some success with these treatments. Second last slide. Huntington's disease clinical research. What is clinical research? Well, that's doing studies on or with patients. It improves the understanding and leads to treatments. Unless we've got trials that we do with patients, we don't learn more about the disease. if it's a clinical trial, and a clinical trial is usually where people with Huntington's disease are given one treatment or a placebo, and we look at the results afterwards. So the clinical trials, if you're involved in a clinical trial, it might actually help you, even though we don't know. But so patients might get some benefit from it, but usually you don't know whether you're going to be on the real one or the placebo. And importantly, the collaboration between clinicians looking after Huntington's disease and the researchers doing in the labs, and Trent Woodruff and various other people you had speak to you before, collaborating with them, we get some insights and we look at different ways of doing the treatment. In our clinic, we've been involved in providing biosamples for basic science research. We've done some sleep studies in the past with Susie Mantovani, and many of you in our clinic will have provided blood samples for genetic studies and inflammatory biomarkers, which has been helpful for research. And we've been involved in clinical trials. Rob Adam conducted the WAVE study, and we're about to start the N-acetylcysteine study. This is for early symptomatic patients with early symptoms. This will be for people who haven't got symptoms yet, that will be starting soon. So there are trials happening, and it's important. And my last slide is just to leave on a kind of a positive, exciting note. I don't know whether Julie spoke about this at all. People know about the fancy new gene modifying kind of trials. So I just thought I'd just try to explain this, because I found this slide and it's quite helpful. So what is an antisense oligonucleotide? How are we supposed to know what that is? So this is your chromosome. So this is a genetic code. We've got chromosome, we've all got pairs of chromosomes, and on the chromosome is where the abnormal gene for Huntington's disease is. So DNA is that's the genetic code on the chromosome, and it's converted into this thing called messenger RNA, and then messenger RNA is converted into a protein. So if this part of the DNA is your Huntington's gene that's abnormal, it's got an abnormally long tail on it, as you know, the CAG repeat that people talk about, the number between 37 and 50, 60, 70, that will then convert into mRNA, and it gets converted into an abnormal protein. And this abnormal protein in Huntington's disease, we think, is responsible for clogging up the cells, clogging up the brain cells, and causing the Huntington's disease. So what these antisense oligonucleotide trials are is something that will bind to this abnormal messenger RNA and cause it to be destroyed, so that your Huntington's gene is still there, but it doesn't end up converting into a protein. So that's what a lot of the original famous Roche trial about 4 years ago, the WAVE trial, they haven't all been successful. We've learned a bit from each of them. And if we can get a very effective antisense oligonucleotide that will block the Huntington's gene being converted into the abnormal Huntington's protein, then that's a really big chance for having something really, hopefully, exciting in the treatment for Huntington's disease. Thanks for your time.